Welcome to Pedo Teeth Talk, brought to you by the American Academy of Pediatric Dentistry, a podcast show that delivers cutting-edge ideas for the professionals specializing in pediatric dentistry.
Good afternoon and welcome to Pedo Teeth Talk from the American Academy of Pediatric Dentistry, bringing you up-to-date information to help you in your practice every day. We're here live recording at the annual session of the American Academy of Pediatric Dentistry in Honolulu, Hawaii. Currently in the exhibit hall at the Tech Bar. And I'm thrilled that I have with me Dr. Travis Nelson of the University of Washington. I get to work with Travis every day, so this is really a thrill for me. And Travis is outstanding in so many ways, and you'll see that today. Travis is the clinic chief of the University of Washington, where I think you said you see around 20,000 patients a year. You have an ambulatory surgery center. You also lead the sedation program. A lot of community referrals. And you're also in charge of an autism clinic. We're not going to have time to talk about that today, but he's done a lot to really bring what pediatric dentistry is in all the ways that it is to University of Washington. So I thank you for that. So anyway, glad to have you here today, and we're here to talk about several topics, but when I asked you about this, you suggested, and I thought it was great, the theme of decision-making and restorative pediatric dentistry, which is such an important thing because in the old days, we had stainless steel crowns and amalgams in the really old days. That's it. And then we had composite, and that was it. And now we have, on one end, SDF, and we've got Hall crowns, and we've got all these different things confronting us. So you kind of put that all together into a sort of a thought process. Is that right?
Yeah, I think so, and I think most of the people who are listening to the podcast today and in the audience have as well. But it's probably worth thinking about having sort of a systematic way of approaching that.
Okay, and that applies obviously not just to restorative dentistry, because if you're talking about SDF, I mean, that is in the spectrum of caries management, so maybe another way to phrase it would be the decision-making in caries management, because some aspect of that is restorative, and of course, sometimes you're not going to be doing any tooth preparation like with SDF or with Hall crown. It's restorative, but you're not prepping the tooth generally, right? So
That's right, yeah. I think that one of the things that's really neat about today and how we practice dentistry is we've got a lot more tools than we used to. I think even 10 or 15 years ago, we don't have the same preventive or restorative options that we do now. So it's a unique and cool time to be practicing dentistry.
Well, there's so many options. So I want to jump right into Hall crowns, because that's, I think it started out as a kind of a controversial subject, and I guess it still is somewhat, and you have people who they say that's heresy. How could you possibly leave the decay in the tooth? Or don't even explore where the decay is, and you're just going to shove something on top of this guy and slam it home and cement it. How could that possibly happen? So if you put that on one end and you put sedation and traditional restorative dentistry with stainless steel crown, speaking of decision-making, so talk to me about that, please.
Yeah, I started doing Hall crowns, I think, 8 years ago, and I'd read the articles, and I thought, they actually have a technique manual for this, so you can go online, you can learn how to do it yourself.
Were you skeptical at the beginning, may I ask?
I think I was, yeah, but then there's pretty high-level evidence that supports it, and then I found that I was doing some sedations, and the sedation wouldn't always work out the way I thought, and I still wanted to get some treatment done for that child, and they might already be numb, but they wouldn't allow to have a handpiece in their mouth. So a tooth or two teeth, we could pretty easily use a Hall crown to finish the sedation successfully and complete treatment for that child. So that's actually, sedation is how I started doing Hall crowns.
Interesting. That is interesting, paradoxically almost.
Right.
And now that you've developed this autism center, would you say that's an area where there's a great need for Hall crowns?
I think so.
Not necessarily more.
Autism is so patient-dependent. There's some kids that would definitely tolerate this, and we've certainly used it with children with special needs. And then there's some kids who it certainly wouldn't be a safe thing to do.
Right. So I guess with Hall crowns, and I think we all know what they are, but the thing is talking about what it is, and then when you actually do it, I call it slam it home, but you're shoving this thing on there, and it goes on there pretty well. So talk me through how you explain to an uncomfortable child what's going to happen. How do you prep them for this? Not to prep the tooth, but how do you prep them for this? And then while you're doing it, what are you saying to them? You know what I mean? I think that's an important part of the learning here today.
Right. Well, I'm going to take it a step further, or maybe a step back.
Sure.
And the first thing that I do is, you really have to convince the parent that this is a good idea.
Right.
Because that seems pretty unconventional. And you say, well, we're not going to be using any local anesthetic. We're not going to be using the dental dam that we may have used in the past. But I find that it's really helpful to just say this is a European technique. And if you say that, the Europeans have been doing this a lot, it sounds sort of cosmopolitan.
Maybe you say with a British accent.
Yeah.
They'll really believe you.
I'm working on that.
Yeah.
So I literally do that. And it's kind of tongue-in-cheek, but the parents think that's kind of fun. So then you get to the, after obtaining consent to do that, then you'll talk with the family and talk with the child. And usually you're having the kids sit upright, so they may be a little bit more comfortable as it is for that. And then always prepare them for pressure. I'm a big proponent of holding the shoulder, giving them a good squeeze to show this is going to feel like a push on your tooth. And then you try it. You get the crown to see basically a little bit of resistance right in the contact area. And then you have the leap of faith, where you essentially have to put it down all the way over.
You don't get a second chance. Or do you?
I've had a few that you didn't go all the way down.
False starts?
It doesn't go as well. Yeah, it's... they call it a child-centered technique, and that's when it stops being as child-centered, is when you don't have one go down. So, nothing's perfect, but I have had a lot of those, especially on little kids who you wouldn't have wanted to sedate, or you wouldn't have wanted to do an ITR-type restoration that wasn't going to last very well. They can be really successful.
Okay. What is the reaction you get from these, challenging kids who are cognitively okay and they understand what you're saying when you explain to them, this is what I'm going to do? How do they react and, then allow you to do it, if that makes sense? I know every kid's different, but maybe you could generalize on that a bit.
So I would never do this on, except for maybe a very, very pre-cooperative, very young child. I would never do this on an unwilling patient. So we get buy-in from them ahead of time. And because obviously safety is first, and we're looking at airway issues if you were to drop a crown. Mm-hmm. So I think it's generally pretty well tolerated. And the child, if you're getting to that point, at least with me, this is not my go-to for placement of a stainless steel crown, but if you're getting to that point, the child has probably already experienced some aspect of dentistry that they didn't like very well. And I give this to them as almost like an alternative. This is something that we will do that will be fairly easy.
Mm-hmm.
Yeah.
Great. So when you're pushing this thing on, you're putting some cement in there?
Mm-hmm. Yeah, gloss ionomer cement.
As you're trying it in, cementing it at the same time. The try-in, the cementation, it's a one-step thing.
I try it in, make sure you've got a good fit first. That can be a little bit of a trial and error, as with seating a conventional stainless steel crown.
Do you ever have the leap of faith, or you just do it all at once?
I don't think I ever have.
Okay.
I'd be bold. Maybe I should try that.
Okay. All right. We need to come up with a name for that. We'll call it the Nelson technique if we come up with
that.
We
might call it the Berg technique.
You need to name something. I always think if you can't name a body part, name a technique, right?
Mm-hmm.
All right. I want to talk about, in this decision-making realm, we've talked about Hall crowns a little bit, and I think we know what they are. And I think my observation is at first it was like, oh my God, I can't believe you do Hall crowns. Not you, but just in general. And now they're becoming fairly accepted. I've seen that transition. I don't do a lot of them myself, but I understand the need for them. And I think those who were like, you can never do those, are starting to be a little more open-minded. Are you sensing that as well?
I think so. I mean, it's like any new technique. It's going to take some while to catch hold. Certainly, if you attend one of the international meetings, you'll see that this is much more an area of research, and it's an area of interest for many dentists. I think that American dentists are also learning that this can be a really cool tool in your box.
Mm-hmm.
That's one of those things that if you have it, you may go months without using it, and then you have that child come through that this is the absolute perfect option for.
Mm-hmm. So I know that Hall crowns, that's the last thing I'm going to get, because I could talk a lot about this, but I want to go on to some other subjects. They were developed by Dr. Hall in England, or in the UK, who is a general dentist. So would you say, in your experience, that it would be easier for you to train a general dentist who's not experienced with stainless steel crowns and the way we traditionally prep them, including anesthesia, rubber dam, the whole business, that would be easier to teach them how to do a Hall crown than the traditional method?
I would say that I don't think it's that challenging to teach somebody to do a traditional stainless steel crown either. But they're not oftentimes taught to do the stainless steel crown.
That's why they were developed, I think, because they really didn't know what to do. There was no pediatric dentist, and that's what happened.
Right, and I think a lot of it is a behavioral thing too, because to provide anesthesia and then have a child who's cooperative for placement of a rubber dam, and so it's just oftentimes not within the skill set of a general dentist.
Yeah.
I think that it's a very easy to learn technique. I tell people if you can seat an orthodontic band, a Hall crown's easier.
Yeah, that's a good point.
Because it won't crumple like a band does if a child bites down on top of it.
Yeah, very good point.
Yeah.
It's a band with a roof.
Exactly.
Exactly. So let's talk a little bit about SDF. We had a big conversation with Dr. McLean this morning. There are dozens of papers here at this meeting about it. So when you think about clinical decision making, we talked about Hall crowns, traditional restorative dentistry, SDF. Every situation is different. But if you could talk us through the decision process, just those three things: traditional restorative, be that crown or intracoronal restorations, SDF, and Hall crowns. What are some of your guidelines? What are you thinking about?
That's a great question. And, every case is going to be unique. But for me, when the patient presents, we get a lot of referrals referred from community health centers, patients who self-refer because they know that we have we have access to an operating room. You're going to have to take each case individually. And when I do that, the first thing I'm going to look at is the patient's age and their health status.
Okay.
So SDF and Hall crowns might be really awesome options for kids who you would want to avoid having sedation or anesthesia that might be required for a very young child. So that definitely is going to start raising up in my hierarchy of options for that patient. Then I'm going to be thinking about, when we talk about age, how long is it going to be till the tooth exfoliates?
Yeah.
Because there's some teeth that you don't even need to treat at all.
Extremely important.
So, and thinking about those types of things, some of the older kids we might think about very differently with materials options versus silver diamine fluoride. And then at the end of the day, we have to think about the parent and the patient. What does that parent want for their child? And to me, it can be kind of challenging because these days, parents want everything, right? I wish I could provide that. I wish I could provide the option that is completely pain-free and is totally aesthetic, and there's zero risk. But the honest truth is that I don't have that option.
No, we don't. It's not Star Trek. We don't have that device Dr. McCoy had that go across the chest and everything is healed.
Yeah,
someday.
Hopefully, next year we'll have that. But not right now.
Not right now. So in the meantime, we have SDF and Hall crowns. So you mentioned before that, ironically or paradoxically, you started thinking about Hall crowns with sedation.
That's right.
So I wanted to ask you, when you plan to sedate, I know you run our sedation program. You do a lot of sedations every year, tons, and you've developed a great protocol for sedation. When you go into a sedation, are you generally planning to do traditional restorative dentistry? Or are you planning to do SDF and Hall crowns? What are your plans going into it?
Yeah, typically these days I am. I don't go into a sedation thinking that we're going to be doing Hall crowns. But there are cases that I feel less confident in the outcome of the sedation. I do our numbers every year, and we probably have between 80 to 85% success in the sedations. Using the scale we do, that means that we got the treatment done, essentially.
It's a good measure.
What
you plan to do.
But there are some children who we've opted to do sedation for relatively limited treatment, and we're finding that the chances of the success, even myself and thinking about that, it goes down from the 80, 85%. And so I say I'm kind of prepped to do that as needed. For me, I would generally opt to do conventional treatment still because I feel like that I'm very confident in my ability to deliver that predictably. You don't have issues with things like occlusion, although with Hall crowns, they typically self-occlude. But I notice more perforations on my Hall crowns, and with the tip.
Does that matter?
Maybe, maybe not. It depends on what you want the lifetime for that restoration to be, what it needs to be.
I was talking to one of my prosthodontics buddies, said one of the reasons I went into pediatric dentistry is I didn't like the semi-adjustable articulator, getting into all that occlusion. We just put a couple crowns on and say, work itself out, It's kind of different. So
we are fortunate, yes.
Hall crown's a good example. So, with the changing landscape, and you have put together in the same conversation sedation we just talked about, SDF, Hall crowns, it makes decision-making on one hand more complex. I know you mentioned earlier that we have more options, but on the other hand, it was kind of easier when we just had this or that. So in teaching future pediatric dentists, who are inexperienced, but they have to get as much knowledge as possible, how do you teach decision-making? How do you, in this complex milieu of opportunities, how do you teach, how do you make, because they don't know what they don't know. So how do you teach that?
I think the thing that I want is for our graduates to go out and have the ability to deliver compassionate and complete care to our patients. And in doing that, that means that they need to be experts in sedation and anesthesia. They need to have excellent surgical skills. They need to do very good space maintainers, really good restorative options, so that restoration is done one time for that tooth. And those things, unless you have the ability to do all of those things, I don't think you're an expert, and that we want to be graduating experts in our program. Mm-hmm. In providing people, you have to give them opportunities. Opportunities to succeed, opportunities to see failures. I think following your own work is a really great way to teach. Unfortunately, in residency programs, oftentimes you don't have long enough for that.
Yay.
So I think exposing to different clinical faculty, exposing to a lot of patient scenarios, that's probably the best way to do that. And then giving people, our residents are incredible. They have got really active minds. They're curious about different options. And so you kind of leave it up to them in some way.
Encouraging to ask questions.
Of course.
And making sure we're not too prescriptive in saying, do that, do this, but this is why, and what would you do, and getting that conversation every time.
Absolutely.
Yeah. And you're right. And then when we have more options, it makes it work for everybody. I wanted to go back again to the decision-making in the context of the sedation and SDF. And, SDF, as you know, I've never seen anything explode in our profession in terms of this rush of attention, this wave that was built so quickly, and literally 2 years ago, nobody was using it. Now everybody's using it. It's 10% of the posters. It's the number one topic. It draws people. If you're going to talk about behavior management, call the title of your presentation SDF and behavior management, and you'll get a big crowd. But my point is, do we still need sedation and anesthesia, or is SDF going to make it all go away? That's a rhetorical question. Hint, hint.
So I was just going to answer that with one word, but so I mean,
how about those Mariners?
Really, right. We've had SDF at the University of Washington for quite a while. Peter Milgram was there, and we had an investigational new drug permit, and so we were using this stuff before anybody else was.
I was using the Australian product for many years.
That's right.
You can do that at the university.
Yeah. So I mean, we've used it a lot. It's awesome. We use it every single day in our clinic, and we still are sedating kids because I've got kids who come in with teeth that need to be fixed. I've got kids who come in with teeth that are too broken to be repaired. I've got children who come in every single day with abscesses. I've got children who have, they're going to need space maintainers and surgical care. And so I think, these things don't have to be one or the other. It doesn't have to be completely polarized. They can be really complementary. I think one of the really interesting things is some people who are real proponents of the SDF as kind of the one-size-fits-all type of a thing, they would say general anesthesia and surgical care has a high relapse or failure rate, which is true. If you look at 6 months out, most of the cases are looking good. You look a year out, and you're going to see recurrent decay with those cases.
So does SDF, though, right?
It's about the same. That's what some people will tell you. It's about the same. But when I look at these surgical cases, they come back and we've restored, let's say, 16 teeth on a kid. All 16 teeth are not going to have broken. All 16 are not going to have developed recurrent decay.
Maybe one or two.
You might have decay at a margin.
Yeah.
Perfect time to put SDF.
Right.
So you can restore the dentition, and you can have rehabilitated the child and have an aesthetic dentition.
Yes.
And then you can deal with things on sort of the little areas that need to be managed.
It helps in the management. And I think the same thing, when I work in the adult clinic, instead of just throwing away a perfectly good permanent tooth crown, fixing that, an SDF will come in handy there as well.
Right.
Yeah, it fits into what you said before. It's an adjunctive thing. It's not a takeaway thing.
And a lot of people, I think, forget about the preventive aspect, is that when this is applied in the mouth, if you have a lesion and you're applying it regularly, then you're reducing the chance of the child to have recurrent decay in the future as well. So it's not only something that we use to arrest caries, but we can use to prevent caries on that child in the future.
Now, we just heard that there's FDA has now allowed this new product with the potassium iodide to come to the U.S. market. I heard it's July 1st. We're going to have a second product. They're making a claim of no staining. You don't have to talk about that because maybe you haven't tried it yet. But how big of a deal is the staining? That's what I want to know. Because do we need a solution to a problem that doesn't exist? Perhaps is it a problem?
The staining is a huge deal to some parents.
Okay.
Yeah, it's a huge deal to some parents, and some parents almost don't care. And it really depends on the parent. There's really good research out now that's looking at that, acceptance rates. And they show that, I think Dr. Crystal had a survey, she and some others had a survey, and they looked at some parents, and they said, for the little kids, when you're looking at the preschool age group, that if the parents were shown photographs of those children and said, SDF, is this okay? Is staining okay in the anterior region? 2/3 of the parents said, no way, right? But then if the parents were given the alternative, well, it's going to take general anesthesia to restore that dentition. It flip-flopped. So you only had 1/3 of the parents who said, I'd like the general anesthesia. Mm-hmm. So what's curious to me about that is that at the end of the day, regardless, there were 30% of patients, 30% of parents who said, no way will I have the staining. But there were a lot of parents who said, I'd prefer to have that staining than the general anesthesia procedure.
Mm-hmm. So I think, and we heard this from some other colleagues, that it gives us a better ability to have a more robust conversation with the parents about various options and gives them an additional option, gives all of us an additional conversation piece. It's an informed consent element. It adds an element to our informed consent regimen.
I show a picture when I do talks on silver diamine fluoride, and it's a picture of pretty severe cosmetic discoloration on a child's teeth.
Anterior teeth.
Anterior teeth,
Mm-hmm.
exactly. And when I talk about that, I put that slide in my lecture to remind myself that I can't really impose my own values on the parent.
Right.
Because that was a parent, a relatively affluent parent with a child who said, I don't care what it looks like on those front teeth. I absolutely do not want pharmacology for her. And they were willing to come back over and over and over again for that option.
You mean GA or sedation when you say pharmacology?
That's exactly right, yeah.
Mm-hmm.
Yeah. So I put that in there because I'm not sure if that's what I'd want for my child, but it doesn't mean that I shouldn't present that option to the parent.
I think the scenario you described before, let's say I have a primary first molar, a commonly treated tooth with SDF, maybe it's partially or fully cavitated. The behavior of the child is sort of questionable. So you have this choice, traditional restorative dentistry with sedation or maybe GA for the rest of them. You have Hall crown and you have SDF. I know you can't talk about it generally, but I think it creates a good scenario for a conversation. So do you have any kind of rules of thumb to help us guide us in that primary first molar, large, partially or fully cavitated lesion, Hall crown, SDF, traditional restorative dentistry with sedation?
Yeah, so I would start with the age of the child. So a lot of times, those are the teeth that are the most destroyed when you bring these little children in, and they're 2 years old. So if you have a child who's got only 16 of 20 teeth that are erupted into the mouth, then you take them to the operating room, there's a pretty good chance in a high caries risk individual that you're going to be retreating those second molars at some point. So the other thing that factors into this, and it sort of almost coincides with that age group, is that there's that new FDA black box warning on anesthesia. And so when you have children who are under the age of 3, they really say that this needs to be a medically necessary procedure. And that calls into question, when does it become medically necessary? So, to your question there, I would say, if we can, if it's a younger child, we might think about temporizing or delaying treatment, arresting caries to get the child a little older.
So we're outside the black box.
Yeah.
Get out of the black box, basically.
Exactly. Yeah, you need to be sort of thinking about
black teeth, no black box.
Yeah, that we get outside the FDA black box.
Okay, got it. So, what about and this is probably my last question for today, and then we'll see questions from the audience. A combination. I'm thinking, SDF. Really, it's a treatment of the biofilm. You're treating the lesion as it's progressing and halting its progression, hopefully, assuming you get the liquid to the extent of the lesion. And then, assuming you restore that tooth, now or later, you're separating the treatment of the lesion with the restoration, both of which are important. So I see a future, perhaps, and I want to see what you think on this, where arguably all restorative dentistry is an indirect pulp cap. All operative dentistry is indirect pulp caps, even an ideal prep, right? So maybe we should be disinfecting or treating every tooth and then restoring it. So what about the combination of SDF with restorative, with or without sedation, or with Hall crown and SDF? What about throwing it all together?
I think it's a great idea. And I think that as we produce materials that are able to opaque and to cover over some of the cosmetically objectionable staining, if it is objectionable to the family, pre-treating these things, if you're able to arrest the decay and decrease the biologic load that is in the mouth, then absolutely. In some cases, I think we still have issues with that amount of staining shining through restorations, particularly composite restorations. But as technology improves there, of course.
So if you have opaquing agents and we get better, maybe we should tell our manufacturers here, give us a better opaquer. We're kind of improvising with what we have. What if we had a great opaquer as part of the kit? You could restore, and then you fulfill all these objectives. Maybe that's what we need. We'll call that the Nelson technique.
Or the bird, or
right
the
here
bird
on
technique.
Pedo Teeth Talk, you heard it first. It's the Nelson technique. I didn't have time today to talk about some of the other things I'm interested in. You mentioned cutting edge, and I'm doing some work with some of the bulk fill materials and resin infiltration, and we talked about those earlier with our other podcast. But I want to have you back because I want to stay in touch with your ongoing work, and I know our audience wants to hear that too. So I thank you, Dr. Nelson, for being with us today.
Thank you for having me. It was a pleasure.
I love doing this. I have the easy job because he's the expert, and I get to introduce him to you. And this is being recorded, and this will be live on the internet in several weeks or a month. We'll let you know. So thank you today for being here, and thank you for tuning in to Pedo Teeth Talk. We're the American Academy of Pediatric Dentistry. Today, broadcasting live from the annual session in Honolulu, brings you cutting-edge information for pediatric dentistry practice. Thank you very much.
Pedo Teeth Talk is brought to you by the American Academy of Pediatric Dentistry, the show that delivers cutting-edge ideas for the professional specializing in pediatric dentistry. If you have any questions or comments, please email info@aapd.org. We welcome your ideas for future shows and guests. For more information on the American Academy of Pediatric Dentistry, visit aapd.org.